Hi everybody, I'm here to present my PhD topic of investigating the consequences of inappropriate antibiotic use in the intensive care unit. I'm an intensive care resident and a pharmacology teacher here at Semmelweis University, and I want to live in a world where every physician can access the most up-to-date resources, and my mission is to provide the best clinical evidence to help medical professionals make the best possible clinical decisions. I have two specific goals, first of which is investigating the effects of inappropriate antibiotic use on complication rate in the intensive care unit, and we are approaching this problem with the method of systematic review and meta-analysis. Inappropriate antibiotic use is not a homogeneous category. It can take many shapes and forms. It can be unnecessary, the spectrum can be too broad or too narrow, or the dosing can be incorrect. The problem with inappropriate antibiotic use, first of all, is that it's very common. What we know is that early antibiotic administration is recommended by sepsis guidelines, and this led to an increased use of antibiotics globally. But we also know that excessive antibiotic use can lead to complications such as the selection of multi-drug-resistant pathogens. The missing link is that we don't know exactly how inappropriate antibiotic use related adverse events affect patient outcomes. And our aim is to unveil the association between inappropriate antibiotic use and complication rate. On the graph, you can see proposed future results of antibiotic use, and if we continue growing, it's going to take an exponential curve. So with this study, our clinical question is whether inappropriate antibiotic use have an impact on complication rate in the critically ill population. We are using a PECO framework. We are investigating critically ill patients to the exposure of inappropriate antibiotic use. And our primary outcome parameters are organ damage parameters. These mainly consist of the parameters of SOFA score, the occurrence of multi-drug-resistant infections, and the incidence of Clostridium difficile. As a secondary outcomes, we are investigating length of hospital and ICU stay and drug-related adverse events. The hypothesis we are testing is whether inappropriate antibiotic therapy increases complication rate in critically ill patients. And our clinical implication for the study is to reduce the incidence rate of multi-drug-resistant infections, decrease the incidence of antibiotic-related adverse events. We completed a systematic search last year with the following search key. And in the end, we ended up with more than 200 articles. The Cohen's kappa is to be calculated because some articles are still under translation. The English articles and the ones that we found which were behind the paywall added up to a 271 article number, and we are in the process of data extraction. By today, it's over 30 articles that has been extracted. This is a screenshot of the data extraction baseline characteristics table, and I included it to show you that these articles are mostly retrospective cohort studies with some prospective ones. They are giving the diagnosis of bacteremia, which is quite heterogeneous on itself, and they are mainly using hemoculture as to define whether the spectrum of the antibiotic was correct or not. As a preliminary result, this is a subgroup of the selected articles for Acinetobacter infections, and the type of inappropriateness we are investigating here is too narrow spectrum. And as you can see, there's a clear trend towards the increase in odds ratio for mortality for patients who received inappropriate antibiotic use, but it is not a statistically significant result. To interpret this result more carefully, we will need the whole data set to draw more definitive conclusions, but as for today, it signifies us that the picture might not be as clear as appropriate antibiotic use means patient survival. The second project we are working on is the procalcitonin kinetics guided antibiotic management in patients with septic shock, and this is the drafting of a protocol of a randomized controlled trial. what is the new definition of sepsis and how it differs from previous sepsis definitions. Suspected septic, we are planning to investigate suspected septic shock patients, which can be due to infections, which are mostly related to pathogen-associated molecular patterns, or a non-infectious injury. And if it's a bacterial infection, the solution of the problem is partially antibiotics, but if it's a hyperinflammation, then no antibiotics are needed because we are not dealing with the causative problem. So what the problem here is that the Surviving Sepsis Campaign guideline recommends ideally within 1 hour antibiotic administration. Although it's a strong recommendation, it's with a low grade of evidence. This leads to the overuse of antibiotics, which can lead to more adverse events. The proposed solution is, as you will see later today, is procalcitonin-guided antibiotic therapy that, according to this meta-analysis done in this institute, may contribute to improved survival and better patient outcomes and shorten the length of treatment. So, in the current guidelines, they suggest using solely procalcitonin as a deciding factor for the use of antibiotics or not. But the previous study shown that the procalcitonin kinetics may be a better indicator for a bacterial infection, with an area under curve of delta PCT of 0.85. The other lines you see on the graph, so the 0.85 is the one on the top. The other lines are for regular inflammatory biomarkers, which are close to the 0.5 line, which means it can go either way. So our primary aim with this study is to assess the effect of PCT kinetics-assisted antibiotic therapy in reducing the incidence of inappropriate antibiotic use with in patients with suspected septic shock. We are planning to investigate lower severity suspected septic shock patients. We define this category as a lower dose of norepinephrine need and a moderately elevated serum lactate level. The intervention group will be the PCT kinetics guided group, and the control group will be the standard of care. The outcome parameters will be organ dysfunction parameters, assess the appropriateness of the chosen antibiotic, and the secondary outcome parameters will be length of ICU, hospital stay, and mortality in itself. The clinical implication for this study is to assess and prove or disprove that individualizing antibiotic use by using PCT kinetics guided approach may reduce unnecessary antibiotic usage and improve clinical outcomes. Thank you for your attention, and I want to end the presentation with the words of Theodore Roosevelt regarding to the complexness of these topics. Nothing worth having comes easy. Thank you very much.
If not, I have a question. What do you think about the measurement of the serum level of the antibiotics? You did not mention when you define the appropriateness of the antibiotics, it might be important as well, isn't it?
Yes, there are studies that we included that specifically target, there are pharmacokinetical studies. In those studies, they only evaluated whether the correct serum level of the antibiotics were reached. They define the correct serum level with the minimal, they are mainly focusing on beta-lactams, and they are assessing whether the minimal inhibitory concentrations, twice of the minimal inhibitory concentration is leached in the plasma. So that's the minimal, that's where they define that it was an appropriate dose. Generally, that seems to be a standard across the studies. So far of the extracted articles, we found 2 studies that evaluated this.
Thank you. And regarding your second project, you want to individualize the antibiotic therapy. Do you think you can individualize PCT kinetics as well? So do you think in different PCT levels in different kind of people as well?
For in the study that I mentioned about PCT kinetics, there were separate subgroups for surgical and non-surgical patients. They tend to differ. Surgical patients tend to have a higher level of starting PCT levels. That's for one thing. The second thing is that PCT clearance can be very individual. So that can't be a strict cutoff value. But as for the today's standing of PCT kinetics, we can only medically underline the use of a standard cutoff. But from this study, as a post-hoc analysis, it could be a good investigative direction.
Thank you.
One question. You have already a preliminary data. I would like to know which are the most frequently appearing antibiotics and the group of antibiotics regarding the inappropriate usage, and if there are any differences between different geographical regions regarding this problem.
For geographical regions, I can't answer yet. But for the use of which antibiotics are used more inappropriately, generally speaking, when they talk about inappropriateness, they tend to refer to a too narrow spectrum. Some articles reported too broad one as well. But for example, for Acinetobacter, in most cases, they report colistin as appropriate and necessary. So for the group that has been analyzed, colistin seem to be the most common. But for other groups, the most common drug class is cephalosporins. But these are very dependent, and not all studies report it equally. So it's really hard to compare them because of the high heterogeneity of the reporting.